Hello and welcome to the AIOS educational module. My name is Dr. Nitika Beri and I will be discussing on the topic Aqueous Angiography Guided Minimally Invasive Glaucoma Surgeries. So I would like to start by asking you all a question. What is aqueous angiography? What comes to your minds when you hear this term aqueous angiography? So to make it interesting, I asked this question to my residents as to what do they think about aqueous angiography? And they answered that some of them thought of it and correlated it with either retinal blood flows or even choroidal blood flows. They thought of it similar to FFA or ICGA, or similar to OCT angiography, or even anterior segment FA. But aqueous angiography is none of the above. Aqueous angiography is a recently introduced technique which allows for real-time functional assessment of the conventional aqueous outflow pathways in vivo and under physiological conditions. Let's quickly revise with the help of these animations. As you can see on the left-hand side, this animation shows the aqueous outflow pathways. 70 to 90% of the aqueous outflow occurs via the trabecular outflow or the conventional aqueous outflow. The rest of it is taken care by the uvascular outflow or the unconventional pathway. The animation on your right-hand side is a schematic diagram of the conventional aqueous outflow pathways. And this is what aqueous angiography aims to image. So let's quickly see what aqueous angiography has shown us. It has shown and revealed a wide variation of aqueous outflow ranging from equal outflow to poor outflow and segmental outflow along the limbus, with the segmental outflow being the most common. Aqueous angiography has enabled us to identify the regions with increased angiographic signals denotive of a high flow region and regions of decreased angiographic signals denotive of a low flow region. In this photograph, the nasal quadrant is the high flow region and the temporal quadrant is the low flow region. We conducted a study for quantitative assessment of functional aqueous outflow in non-glaucomatous subjects using aqueous angiography, and we found that the mean signal intensity was the highest in the nasal quadrant and it was the least in the temporal quadrant. The study was conducted in 30 subjects. We used image-chase software to analyze the mean angiographic signal intensity along 4 quadrants and 8 sectors as shown in this photograph. Now that we're familiar with what aqueous angiography is, let's see how it is performed. We use 0.1 ml of 0.1% indocyanine green dye, which is injected intracamerally into the eye, either prior or during any intraocular surgery, such as phacoemulsification. The dye is injected prior to the capsulorhexis step, and the aqueous channels are visualized with the help of a flex module of OCT machine in the operating theater with the patient lying supine. Just like a cardiologist performs targeted stenting of coronary vessels using coronary angiograms, similarly, aqueous angiography allows the glaucoma surgeons to perform targeted MIGS. Let's walk through this together. Targeted placement of incision or stents in the high flow or the low flow regions identified by aqueous angiography can be performed. Before we move further, let's quickly revise the types of MIGS surgeries that can be performed on Schlemm's canal. There are stenting procedures, such as an eye stent inject. There are cutting procedures, such as BANG or the bent ab interno needle goniectomy, and there are dilating procedures, such as ab interno canaloplasty. Let's look at them case-wise. So bang was performed in the low flow region in case 1. Pre-bang aqueous angiography was performed and the temporal quadrant, as can be seen here, was identified as the low flow region. Bang was performed in this low flow region. We can see in the video the 26 gauge needle creating the goniectomy cleft as the bang is performed. And this was targeted in the low flow region. Post-bang aqueous angiography showed opening of previously collapsed aqueous channels, as can be seen by the arrows. In another case, bang was performed in the high flow region. In this case, pre-bang aqueous angiography identified the nasal quadrant as the high flow region. Bang was performed in this high flow region. Post-bang aqueous angiography showed increased angiographic signals in the nasal quadrant, suggestive of increased flow post-bang. We all would like to know what happens to the goniectomy cleft over time that we create during the bang procedure. Aqueous angiography has helped us to evaluate the cause of failed MIGS. Let's see this case. In this case, pre-bang aqueous angiography identified nasal quadrant as the high flow region. Bang was performed in this high flow region. After 2 years, there was a rebound increase in IOP requiring trabeculectomy surgery. Aqueous angiography was performed just prior to trabeculectomy, and we found that there was a loss of previously functional aqueous channels. This comparative photograph shows loss of previously functional aqueous channels, and this was seen as fibrosis of the cleft on ASOCT. With these clinical findings, it tickled our curiosity as to whether we should perform bang in the high flow region identified by aqueous angiography, or we should perform bang in the low flow region identified by aqueous angiography. To answer this query, we performed a pilot randomized controlled trial in patients of primary open-angle glaucoma and defined success as achieving a postoperative IOP of less than or equal to 15 millimeters of mercury, but more than or equal to 6 millimeters of mercury at 6 months with anti-glaucoma medications. The results of our study at 6 months was that a higher postoperative success was noted in patients who had undergone bang in the low flow region, which was mostly in the temporal quadrant, compared to patients who had undergone bang in the high flow region. And this difference was statistically significant. On further Kaplan-Meier analysis, we found that the mean survival of the patients who had undergone the low-flow bang was higher compared to the patients who underwent the high-flow bang at 6 months of follow-up, and this difference was also statistically significant. The study concluded that bang in the low-flow region gives better results over 6 months compared to bang in the high-flow region. Armed with the above knowledge, let's see the clinical applications. MIGS, especially bang, should be performed in the low flow regions. Previous studies on aqueous angiography have found that maximum functional channels occur in the nasal quadrant and the least functional channels mostly occur in the temporal quadrant. Hence, as an extension, we can say that where there is non-availability of aqueous angiography, MIGS in the temporal quadrant is a simpler way to target the low flow regions. Yes, I agree with you that it is technically more difficult to perform MIGS in the temporal quadrant, but practice makes the man perfect. With practice, procedures like bang, visco-bang, Tanito microhook, and KDB can be performed in the temporal quadrant. Another alternative we can propose is perform aqueous angiography, localize a low flow region in the nasal quadrant, and then perform MIGS in that region. Moving further, another clinical application of aqueous angiography is the intraoperative functional assessment of MIGS. Trabecular stenting procedures were evaluated. On the left side of the screen, we can see two anatomically well-placed eye stent injects. And on the right side of the screen, we can see that on aqueous angiography, there was only one functional stent. Looking at this more closely in figure B, we can see that the yellow arrow is pointing towards the functional eye stent inject denoted by the yellow asterisk. But there was absence of collector channels through the eye stent marked with the red asterisk, even though it was anatomically correctly placed. We feel that the above clinical finding may be attributed to the variations in the position of collector channels, that is, the segmental aqueous outflow as seen by aqueous angiography. Our take-home messages are: 1. Let's try to perform trabecular cutting MIGS in the low flow region or the temporal quadrant and spare the already functional channels. 2. There is a possibility of non-functional stent despite a correct anatomical position. This can be likely due to placement of stent in the area of collapsed or absent collector channels. Here, aqueous angiography may be beneficial as it can assess intraoperative functionality and allow for adjustment of the stent in the same sitting if required. I would like to acknowledge my mentor, Professor Tanuj Dada, and the team. Thank you for watching.